Everyone, this is Dr. Peters, and I'm going to do a quick wrap-up video on this last week's topic, perioperative. So I work in a pre-op clinic, so this is my thing. And what I'm going to do is, in a practical way, explain to you the entire process in a nutshell. So I drew 3 circles here: pre-op, periop or intraoperative when they're during surgery, and post-operative. And my job is over here, and it's because we have to address everything here in order to reduce complications here and here. So we do what we can. You may hear in the lingo as you move on the terms preoperative clearance. That is really not recommended to be used anymore. So it's kind of a pet peeve of mine. We cannot clear anybody for surgery because nobody is risk-free. And so we call it risk stratification. So we want to figure out what their risks are and reduce them, or at least give some suggestions of what we can do to at least reduce the risk. Or sometimes they're too high of a risk that we have to say, no, you can't have your surgery. All right, so over here, when I have a patient come into the office, I make sure that I go over these risks: cardiac, respiratory, nutrition, cognitive, DVT risk, and mobility, as well as some other things, and anesthesia. I want to make sure, and when I talk to the patient, I say, I want to make sure you're ready for surgery itself. So if they're having, let's say, their appendix removed, I want to make sure you're okay to have that surgical procedure. I want to make sure you're okay for anesthesia, and I want to make sure that you're okay for recovery, and we give you enough information so we can prevent complications. So if somebody comes in, when I say cardiac risk, every patient gets an EKG for the most part that walks in the door. There's other things that we break down. If they're having a cataract surgery and nothing going on, we don't need to get an EKG. These are all based on guidelines that are put forth by research. So let's just use the common moderate risk surgery, like an appendectomy or a knee replacement and that kind of thing. Do they have any cardiac issues? Do they have heart failure history? Do they have an MI history? Do I need to send them to cardiology to make sure that they don't need a stress test prior? Many times I catch abnormal EKGs and I have to do a stress test. Believe it or not, in this area is where we catch a lot of things. We've caught cancer, we've caught heart attacks, past heart attacks, kidney disease, diabetes that hasn't been diagnosed at all for years. So this is a really important job to have, and I love it. So, all right, respiratory. Do they have a history of COPD, asthma, sleep apnea? Sleep apnea increases the risk of having post-operative issues. Just like smoking, they stay on the vent a little bit longer perhaps, depending on the surgery, but they're at higher risk. All right, so those are some of the respiratory. And how do I determine how much risk they are in? I have screening quizzes that I go through, or they're called tools, assessment tools that I have. It's called the perioperative and it's made, actually it was developed by a physician at the Medical College of Wisconsin. It's a fantastic site, and all I have to do if I have a question, I go to that, it tells you exactly what to do for each of these. Nutrition status. Does the patient have GERD? Are they obese? GERD meaning esophageal reflux. Are they obese? Do they have poor nutrition? Are they elderly? Those are all things that I look at. If you want to know more details, I can certainly give you that. Cognitive. Are they elderly? Are they at risk for post-operative confusion or delirium, we call it? Are they a drug user? Are they an alcoholic? Those are all risks for waking up confused. So I need to put that in my notes to let the anesthesiologists know, the surgeons know, and the nurses know on the floor. So if you guys do anything, any surgical care on the floor, make sure you read the pre-op note, because it really should involve a wealth of information. If it came from a pre-op clinic, it usually does, because we are required to make sure we're addressing all these issues, which is why pre-op clinics are now more popular than they used to be, because it does take up a lot of time. I have an hour with each patient. All right, DVT risk. Again, are they abdominal surgeries? Increase the risk of DVTs. Are they obese? There's a slight evidence that shows if you're obese, you're less mobile. Are they having surgery on a knee and they can't move it? Are they having any lower extremity surgery? That puts them at risk. Mobility and other kidney disease. Do they have a history of anemia? And lastly, anesthesia risk. So I want to know if they've had issues with anesthesia in the past, even nausea and vomiting post-operatively, because we can give them medications to prevent that. But also, do they have a family history of anesthesia issues? Malignant hyperthermia, very rare, but we need to know about it. It doesn't mean they can't have anesthesia, they just give them a different cocktail of anesthesia. It used to be years ago where, oh, that's very dangerous. It is dangerous, but now it doesn't mean they can't have surgery. Then lastly, but most importantly, is teaching and the consent. So I talk to the patients about all their risks. I say, you have sleep apnea, you need to bring your CPAP machine with you to surgery, because over here, they're going to make sure they have their CPAP on. And it lets the team know that they have obstructive sleep apnea or a different kind of sleep apnea. So we're gonna do a lot of teaching. Make sure the two things that I tell every single patient across the board is coughing and deep breathing and ambulating. We know over here there's going to be tailored instructions for them depending on the surgery. But overall, coughing and deep breathing, you want to prevent pneumonia, you want to get that fluid going, you don't want anything settling in the lungs. Cough and deep breathe as much as you can. Incentive spirometers are important, those little contraptions. I love them. Even patients I've diagnosed with pneumonia, I get them one, and it really helps expand their airways, because usually when we're breathing, we're not breathing fully on purpose. And here, you are not breathing to the full capacity. So that's why you're at higher risk for this. So if you're under anesthesia, the longer you are under anesthesia, the more risk you have for that. All right, and informed consent. If this patient still has questions about this surgery here, they should not be signing a consent, and you should be getting a hold of the surgeon to answer those questions for the patient before they sign on the dotted line. So that's very important. Then let's go over here. Airway, very important, obviously, right? We want to make sure they're alert oriented, because if they're agitated or not feeling right, a little confused, many times it's this, their O2 sat is just down. And we see this a lot when I used to work in recovery room or PACU. They would wake up and their SATs would be in the 80s. So we had to lift up their jaw and tell them to cough and deep breathe until they're awoke enough. So sometimes we've had to reintubate, and that just depends on how much anesthesia they get too. Vital signs, always important, especially the first couple of days. You want to monitor that blood pressure and make sure it's not going too high or too low. Are they bleeding out? You're going to look at incision care. Are they bleeding out? Again, you check the vital signs. It's normal to a point to have a low grade temp. So at that point, if anybody has a low grade temp, I say, let's get up and walk and let's cough and deep breathe. You don't want any pneumonia kicking in, and it very well could just be they need to get going. Mobility, because I don't want this patient to have a DVT. So these are very important. Incision care is important too. So we talked about that, which is why vital signs and the airway is so important, because this can tell you a lot. If you're seeing, it's a little bit red around, it's bleeding more around that surgical site, you mark it, and then you notice it's a lot more within a short amount of time. What if their blood pressure is low, they're hypotensive, tachycardic? Tachycardic meaning at least 120, are they bleeding internally? And on the opposite end, why is their blood pressure too high? We don't want them to have a stroke or any other complications. And all this risk is from this pre-op thing. Why do they have the risk? Okay, what did they come in with before? If they have kidney issues, you're going to maintain their fluid balance. You're going to watch that carefully. If they're diabetic, you have to watch that carefully with checking blood sugars and healing. Over here, if I have a patient with high blood sugars, or A1C we call it, the average blood sugar over 3 months' time. If it's over 8.5, depending on the surgery, I cancel the surgery because they're going to have problems here. Like cataracts, if they're above 9, they get canceled because it actually changes the shape of your eyeball, and the cataract surgery, it's not going to be beneficial or accurate. So we need to wait till we get those blood sugars down. Alertness, post-op delirium, nutrition, make sure they're getting enough protein, and teaching. Coughing and deep breathing, walking, because we don't want them to get a DVT. So I tell them, if you feel like you're having a swollen leg, if it's red, it's warm, that could be a DVT, and that's dangerous. All right, so that's this in a nutshell. If you want to know anything more details, just please email me and let me know.